Ovarian reserve assessment and patient categorization actually, that share is not working. Actually, ovarian reserve is a term used to describe the functional potential of the ovary and reflects the number and the quality of oocytes within it. Why we are detecting or predicting ovarian reserve? It is predicting the chances of pregnancy and live birth rate with or without treatment, and selecting an optimal protocol and the dosage of ovarian stimulation. For whom shall we choose ovarian reserve testing? Actually, we should test the ovarian reserve for all of our EXE patients to diminish ovarian hyperstimulation test syndrome and unexpected poor responders. And we should give special importance for patients over 30 years, special importance for patients with history of exposure to a confirmed gonadotoxin, and with patients with strong history of early menopause, and patients with extensive or previous ovarian surgery. Actually, we all know nowadays we should give a great importance for well assessment of ovarian reserve to choose the best protocol, because one of the most important success key in the EXE cycle is to try to have more oocytes. And all we know, this very famous research by Sankara that documented the association between the number of eggs. The more eggs we have, the more live births in the EXE or IVF treatment. This was on the analysis of a very large number. Not only this, but also in poor responders, we should have more oocytes because, like we see here, in patients below 35 years, we should have 5 metaphase 2 oocytes to have 2 plus in day 5. And in those 2 plus, only like 50 or 60% of the 2 plus will be euploid blastocyst. And this is our aim. Actually, when we stimulate or transfer embryos, we would like to share more or to transfer the more euploid blastocyst to have more success. And the more age, if we are dealing with a patient like 39 or 40 years, we can see that in every 8 metaphase 2 oocytes, we can find at day 5 only 3 blastocysts and 1 euploid blastocyst. The more age, like 42, to gain 1 euploid blastocyst, it is only 1 in each 5 blastocysts at day 5. And so if we have accurate ovarian reserve assessment, accurate antral follicle count assessment, we will give the best protocol or the good protocol suitable for the patient, and we will have a better outcome. The markers of ovarian reserve, as we all know, are static tests and dynamic tests. But today we are speaking about the ultrasound, and so we will concentrate on the antral follicle count. To cut it shortly, this is the latest EFRE guideline for ovarian stimulation that documented that pre-stimulation management for predicting high and poor response to ovarian stimulation, we should use either antral follicle count or anti-Mullerian hormone. So you can use antral follicle count by ultrasound or anti-Mullerian hormone, and both of them are recommended over the other ovarian reserve tests. The clinical implication of these tests, regardless the change in the management with the purpose of improving the efficiency and safety, have not been evaluated yet. Actually, you can use antral follicle count alone, you can use anti-Mullerian hormone, or you can combine both of them. And we prefer to combine both of them because the more accurate you are, the best outcome you can gain. To give more about antral follicle count measurement, antral follicle count refers to the number of antral follicles in both ovaries, not only in one ovary. And so this is the total number of antral follicles in both ovaries. We should not be mistaken with what is known as follicle number per ovary, FNVO, which is useful only in gynecological practice. We can diagnose by this some gynecological diseases. A normal ovary should have a volume of at least 3 with at least 5 to 15 antral follicles. According to the number of oocytes we can gain in the lab, we can classify our patient that they are maybe poor responders, suboptimal responders when we are speaking between 4 to 9, normal responder from 10 to 15, or hyper responder more than 15. This is an ultrasound picture of the antifollicle count of normal responder, high responder, and the category of low or subnormal responder we can classify to low antifollicle count and very low antifollicle count. The low antifollicle count is from 5 to 9, and the very low is from 4 to 0. This is the classification if we are counting for one ovary, but as we say in the infertility management, we should calculate both ovaries and manage like that from 0 to 4. This patient is very high risk for poor response. From 5 to 8, high risk for poor response to ovarian stimulation. This is subnormal response. The normal responder patients is from 9 to 19, and more than 20, the high risk, 20 or more high risk of excessive ovarian response and ovarian hyperstimulation syndrome. This classification is very important and very important to decide before you start your stimulation and decision of the protocol. Antifollicle count measurement is a non-invasive, easily performed. It should be performed using transvaginal ultrasound with a frequency 7 megahertz or more. And for training, we suggest that minimum before the candidate start to assess the antifollicle count routinely, you should have 20 to 40 supervised examinations. Antifollicle count may be evaluated using the normal real-time 2D ultrasound or stored 2D sine lobes ultrasound, and maybe 3D ultrasound if the facilities are there. It is recommended to count the follicles in the early follicular phase of the menstrual cycle to prevent the effect of intra-cycle fluctuation. Evaluation of ovarian reserve by follicle count may be performed at any point of menstrual cycle. Variation of antifollicle count during the menstrual cycle may be as much as 30%. And so when you count the antifollicle in the early follicular phase, this will give you an accurate result. But if your patient is coming delayed and she is quick and you have to go on for stimulation, you can count it, but you should know that there is some fallacies around 30%. And this doesn't affect the choice of a stimulation protocol normally for in vitro fertilization. Antifollicle count may be reduced in women using hormones, and so they should stop as much as we can 2 months of hormones before you are counting antifollicle counts, like hormonal contraceptive pills or gonadotropin-releasing hormones agonists. The degree of reduction will differ considerably between patient and another patient, and when you are counting normal or high responder, this is still be useful in clinical practice to count, even if the patient is taking hormones, it will not differ a lot. And maybe the stop of taking the pills will be not an acceptable measure in some patients in some times. But this, of course, may be applied to some groups of patients. When we measure the antifollicle count, we should see it as round or oval. And if it is round, we can have only one diameter, or oval, we can have the two greatest diameter and divide them. 3D ultrasound has shorter examination time and it enables storage of acquired data. But actually, we don't so much need for these facilities. Can we use transabdominal route? Yes, you can need to use transabdominal route when the ovary is located cranially and anteriorly in the pelvis or abdomen, or when a transvaginal approach is not recommended, like in virgins, or when there is a pain or vaginismus. Also, we can, in some special conditions, to use transrectal scanning. We can use also the Sono EVC, which is a new development in the new machines of ultrasound based on volume calculation. And we should position the patient in the lithotomy position with an empty bladder, scan the ovaries both longitudinal and coronal planes. And very important, you should have the ovary occupying at least 50% of the screen along its large axis to be able to see very good the antifollicle count. And when it is doubtful whether a follicle lies within 2 to 10 millimeter, follicular size is measured using the internal diameter. We should measure number of follicles less than 2 millimeter and more than 2 millimeter is to be subtracted from the total number. And so after we calculate, we should subtract the follicles which is less than 2 millimeter or more than 10 millimeter to be accurately. And one of the most important issue, if you can use harmonic imaging, because it may improve the image quality, as we see here in the left picture, by reducing artifact when ovaries are closed. And actually, the real time is better than the other facilities because we can determine whether there is an adjacent anechoic structure to the follicle as Ovarian cyst or hydrosalpinx. And we can apply pressure to the abdomen to check the motility and the sliding of it. It allows the use of color Doppler also in the real time. So this is a summary of comparison between the methods present to see the intrafollicular counts. Actually, the real time may be the most common and maybe the standard to use. The sine loop has the same characteristics, but reduces the scan time and allows offline diagnosis. The 3D manual mode, better reproducibility compared with 2D ultrasound, requires a specific training and complex ultrasound systems, and I don't think that it adds any difference. The Sono EVC is a semi-automated method. It is present in the very brand new machines and expensive machines, require trained sonologists and complex ultrasound system. Actually, it gives colors and sizes by colors and table for the follicles. It may be beneficial in some patients with extreme responders. May be beneficial to count and to give a count in a report for the very high responder and in the very low responder. And this is another mode which is called the render mode. And this is the coloring mode which is giving table, and this is the 3-dimensional. After we finish, we should give the patient the report identifying the day of the cycle, whether the woman is using hormones or not, report the number of follicles with diameter between 2 and 10 millimeter, and record which technique was used for evaluation, and note the presence of dominant follicles, cyst, or tumor, and comment on the accessibility. And this is very important, accessibility of each ovary, and this will differ during OBU, like Professor Ahmed will give us an idea about soon. This was the initial assessment, but this is about the count and the number. And there are other important parameters that we can see and test by doing or after doing EXI, after starting examination or stimulation for the patient, what is called as FOI and FORT. What is FOI? FOI is the follicle to oocyte index. Actually, it is very important how much of the intrafollicular count will give oocytes to the lab. So if you start with a patient like this, we see by intrafollicular count like 15 to 20 oocytes or 20 intrafollicular. And by the end of the day, when we retrieve the patient, the lab tells us that we have like 13 or 15 oocytes. And so this is a good FOI. This is around 70% output in the lab from the initial intrafollicular count. And so if you have FOI, more than 50%, so this is a normal FOI. This is a normal output. So you see intrafollicular count, you give stimulation, you have enough oocytes from this intrafollicular count, so you stimulated well, you give good drugs, and the patient has good response. While this patient has 4 intrafollicular counts, if by the end of the day we have 1 oocyte in the lab, this is a bad FOI. The fourth actually is discussing how much the intrafollicular count will give, which is 16, will give 16 to 22 millimeter follicles at the end of stimulation. So it is comparison between the initial expectation at the start of stimulation and what we find at the end of stimulation. If you find at the end of stimulation 70% from what you expect, more than 16 millimeter at the day of SCG, so you have a good FORT. If you find less, this is a bad FORT. And this is talking about the responsiveness of the patient. And so it is not only the count in front of you in the intrafollicular count, but it is also about the response of the patient. And so this leads to a new concept in classification of the patient especially in the poor responder patient, what is known as Busaidon criteria, which is emerged in 2016, changed the concept from proper responder to low prognosis patient. Busaidon criteria designed based on clinically relevant criteria focused on diagnosis and management, quantitative parameters like ovarian biomarkers, follicle count, and AMH, and also qualitative parameters. Qualitative parameters, very important to consider the age, because if you have a young patient below 35, it is totally different from the older patient above 35, because the rate of aneuploidy is different, as we mentioned in the start of the lecture. And also the experience from the previous stimulated cycle is very important. And so they classified the poor responder patient into Busaidon group 1 and Busaidon group 2. Those are the unexpected hyperresponsive patient. Those patients, by figures, the follicle count is more than 5, and so should consider to be okay. And the AMH is more than 1.2 or more. And if you consider this patient to be good, and after stimulation, you find few oocytes gain in the lab, so this is a hyperresponsive patient. If the patient is below 35, it is Busaidon 1. If the patient is above 35 years, it is Busaidon 2. And so it is more complex. Why we find low FOI in this Busaidon? So all Busaidon 1 and 2 are low FOI. Because maybe the low gonadotrophin dose you started, you need more dose. Maybe there is a genetic precipitation like in the receptors for the gonadotrophin. Maybe asynchronous follicular growth, and this made a problem. And maybe a technical issue in the clinician or in the lab during ovum pickup. And so as we see here, there is a difference. If there is, if we made receptor assay, we can find difference between patients. And so this is a recent analysis. And we hope to start soon in Egypt to apply. It is present in many countries. And by this non-expensive study, we can find or define the patient who have a receptor mutation and have difference in response. The Busaidon group 3 and 4, those are frank poor responders. They are patients with anti-Mullerian hormone lower than 1.2 and follicle count 5 or less. And those patients, if they are less than 35, they are Busaidon group 3, and more than 35, they are Busaidon group 4, and those are the most difficult patients you should be careful about, and they should not be delayed in the management. So after we classify our patients by using the parameters, the follicle count, the AMH, and even considering FOI and FORT, we should classify our patient to high responder, poor responder, and the others are the normal or average responders. How can we manage? Which protocol we will choose in the start of our cycle? This is a very important and comprehensive meta-analysis. I advise every one who is practicing easy to read about GnRH antagonist versus the long agonist protocol, which way we can go. Actually, you should say that the antagonist and agonist protocol, both of them are very nice cars that you can go to the airport to start your trip. It is like a comparison between Mercedes and BMW. So you can go to the trip by any type of vehicle. Both of them are okay. But you should drive well, and you should drive with the suitable drive. And you should consider that the journey is not only to the airport. You have another journey after you have your plan to go to the other country. And so the pregnancy is another very important and maybe more important trip. And so the GnRH antagonist actually is considered the best protocol for the hyperresponder patient. It is safe and effective, and definitely you should counsel the patient that we probably may need to freeze all the embryos and transfer in another cycle to be more safe and to give agonist trigger to prevent ovarian hyperstimulation. Actually, this was confirmed in this meta-analysis that the antagonist protocol is more safe in PCOS patients and in hyperresponder patients. And for the poor responder patients, this meta-analysis and also the guidelines confirmed that both protocols are okay for the patient, but we may prefer, and I think in most of us in Egypt, to refer the antagonist protocol also for the poor responder patients. And so the remaining question in the normal responder patients or the average responder patient, to prevent LH surge, should we use agonist or antagonist protocol? We can read this very important conclusion that based on this systematic review, one could argue that in general, with regard to effectiveness, ongoing pregnancy rate, the use of the longer protocol, agonist protocol, remains superior and could still be regarded as a potential first choice approach for prevention of premature luteinization. But this should be weighted against the moderately higher chance of developing ovarian hyperestimation syndrome in women with PCOS and poor responders. Application of GnRH antagonist as a first choice seems justified. And so we agree that in PCOS and poor responder, antagonist is the first choice. And in average or normal responder, you can use both, but up to the moment, according to the authors, the longer protocol is more preferred. And in also my experience and a lot of my colleagues, maybe this is a preferred protocol. If we have a look for the guidelines lately from the EFRE, it confirmed that the GnRH antagonist protocol is recommended for the PCOS patients with regards to improved safety and equal efficiency. The GnRH antagonist protocol is recommended for predicted high responders with regards to improved safety and equal efficiency. And so for the PCOS patients and the hyper-responder or high responders, we recommend the antagonist protocol. And the GnRH antagonist protocol is recommended for predicted normal responder. Here, the guidelines recommended the antagonist, although both of them are equal, but as regards to safety, because like you may find hyper-responsive to the stimulation, you may find unexpected hyper-responsive to the stimulation. So from the normal responsive patient, you should be also careful. You can use agonist or antagonist. You can follow the Lambalk et al. From the systematic review, or you can follow these guidelines from EFRE that say that both of them are okay, but maybe the antagonist is more safe. This is a very nice diagram. Those doses are just suggesting doses or initial suggesting doses. For the high responder, you can start with 150 international unit. For the normal responder, from 2 to 3 amps. For the poor responders, with 300 international unit amps, and most of the literature recommending that no benefit to give higher FSH. This nice diagram you can follow if you combine studying by AMH and antral follicle count. This paper by Peter Busaidon published in Human Reproduction, and this very comprehensive figure you can all of you can keep with you by also classification of the patient. This from the EFRE guidelines to low responder, normal responder, or high responder. And as we see here in the high responder, it is recommended to use GnRH antagonist, as we say, and in the poor responder also GnRH antagonist. In the normal responder, you can use both of them. And in the average, we can start with 2, 3, or 4 amps, and definitely the dose is changing. And after that, you can follow up by ultrasound, and this will be the lecture, next lecture of Professor Ahmed Khalifa. And thank you very much, and I hope it was clear.